Thank you everyone for coming to this session. We're going to make sure that we build in some question time so that you can ask the questions that I'm sure you have for people. My name's Sharon Lawn and I'm here at Flinders. I probably know some of you. I know I've said hello to some people. We've got three really great speakers today. First of all, we have Clara Bookless, who is here in Adelaide, and Clara is a psychologist. Then psychoanalyst, and Clara's going to introduce herself. Then we'll hear from Jackie Amos and then Sathya Rao. So without further ado, I'll get on with it and get out of the way and let Clara tell you all about herself.
Okay. Thank you very much. I really would like to thank the organising committee for inviting me to speak today. I'm actually quite excited to be here. And so I'm going to be talking about, it's already been raised, but broadly speaking, mentalisation based therapy. I just think, actually, I'll just move it on, just to raise a couple of names here. Professor Peter Fonagy, Anthony Bateman, Mary Tajay and John Allen have all been very instrumental in the development of this particular approach, and the ideas do go back well over 20 years. As a matter of fact, they go back way earlier, but still. So I just wanted to acknowledge that this draws very heavily on the work of these sort of central people, particularly Peter Fonagy and John Allen initially. But these days, there's been a tremendously creative sort of explosion, and mentalising is sort of just everywhere at the moment. And you know, so you can see, although it was designed originally for the treatment of borderline personality disorder, it's now used in family work, with children, adolescents, eating disorders, a broad range. And in each case, the programs are sort of adjusted to suit. But originally, it was designed for borderline personality disorder. I thought I'd start by just giving a very brief background as to how I came into this area, how I sort of developed an interest in it. So I've already noticed today several speakers mentioning a very negative attitude to the treatment of borderline personality disorder. And during the 1980s and 90s, I used to work on psychiatric wards, and I was really struck by the very negative attitude towards these patients. In fact, they were discharged very quickly from hospital, and there was generally the attitude that has been expressed here today that clinicians really didn't feel that borderline personality disorders could actually benefit from any treatment. And it always, I never really understood it. And I actually recall at the time a visiting psychiatrist from Britain who was just hit a brick wall about this, and he kept saying, but surely we can treat this, you know. So he tried, but it didn't get very far. Anyway, that actually really stayed in my mind. So that's going, 20 odd years back. Then after that, I became more interested actually over time in attachment theory. And it was from a sort of interest in attachment theory and reading Peter Fonagy's wonderful book, recommend to all, Affect Regulation, Mentalisation and the Development of the Self. And I sort of came to this not long after it was published, actually, and I just thought, this makes so much sense. It's pretty dense, but it really gave me a way of thinking about working with people who at that time I was really quite involved in a lot of the women's shelters around Adelaide, and there I saw firsthand the difficulties that the shelter staff faced in sort of trying to manage and work with women who had borderline personality disorder, and just what a huge issue it was for them. But in particular, when they were trying to parent. Again, this has come up already today. So this was my interest early on then, was looking at the mother and infant relationship. So I go back to infancy. So this is what I call early intervention, mother and infant work at this point in time in my career. So because the mothers struggled so much with being a mother. Becoming a parent with a borderline personality disorder is so challenging. And I hope to get onto that, if I have time, a little bit later in this talk. What I thought I would do today, though, is, because there's so much to talk about within the area of mentalisation. It is a very dense theory. So what I thought I would do is try and look at some of the rationale behind it. Because what I find as I teach or supervise in this area of mentalisation, that it's actually quite, the struggle is getting your head around what it's about. And in fact, so that's why I thought what I might do today is try and give a bit of a background to that. So I'll just look at a definition. Mentalising is the imaginative mental activity that enables us to perceive and interpret human behaviour in terms of intentional mental states. So, mental states include, for example, needs, desires, feelings, beliefs, goals, reasons that we give for doing things, dreams, hallucinations. So it's a way of looking at how we interpret what we experience in terms of mental states within ourselves and others. It's, from that point of view, a very complex idea. It presupposes the ability to direct one's attention to relative aspects of intrapsychic and interpersonal phenomena. And for the most part, it's implicit and automatic. I mean, in daily life, we mentalise each other constantly by attributing intentions to each other, consciously or unconsciously. We're doing it all the time. We're always having to sort of work out, appraise, in a sense, interpret what's going on, to manage. But the problem is, because of the very nature of our minds, it's often the case that our mentalising fails, in the sense that we often misunderstand ourselves and we misunderstand other people. And as we know from our own experience, how awful it feels to be misunderstood. The sort of reaction that you experience when you know you've been misunderstood. However, we can never be absolutely sure, of course, of what other people are thinking or feeling. And our own thoughts and feelings also are often very unclear and inaccessible to us also. So this, with borderline, people with borderline personality disorder though, have particular difficulty with this. And it is this area that the MBT, Mentalisation Based sort of treatment or therapy approach, was originally designed for the treatment of this particular problem. In a sense, the failure to be able to keep thinking in the heat of the moment, so to speak, and to think about intentionality. So individuals with borderline personality disorder may be quite normal mentalisers, except in the context of attachment relationships. It's here that they tend to misread minds, both their own and those of others, when they're emotionally aroused. So the more intense, the more important the relationship becomes, the more likely that one's thinking goes off rail, so that it becomes incredibly difficult to think clearly about what might be happening in oneself and the other. So as the relationship with another person moves into the sphere of intense attachment, the intensification of the relationship means that their ability to think about the mental state of another can rapidly disappear. So what is it about this MBT approach then, if we accept this idea? Well, impulsive and destructive features of borderline personality disorder have at the core a sense of an emotional collapse, if you like. And by this, what I mean is that thinking stops or it's markedly impaired. And without the reflective capacity, the individual risks being, in a sense, lost in emotion. So MBT targets this particular problem of impaired thinking by focusing actually on the process of thinking, not so much the content. So this is one area where this really differs. It's very much around enabling and facilitating the capacity to start to be able to think again, not the content. And I will show you a role play of Anthony Bateman in a moment, and hopefully some of these ideas, if you could sort of keep them in mind, you might begin to see what he's trying to do in the role play. So it's a process-oriented procedure, actually. In particular, this therapy involves thinking about how people interpret and make sense of each other's mental states. That's the focus of the therapy. That is, it focuses on intentions and beliefs, etc., that I mentioned earlier. So in other words, it's not insight-oriented. It's not about trying to link up the past and look at how things connect in that sort of way. So it's a very important point that it's not insight-oriented. Rather, the aim of MBT is limited to enhancing a person's capacity to think about their own behaviours and the behaviours of others. So the rationale then is that when cognition is malfunctioning, it's putting the individual at an enormous risk. Peter Fonagy states that a person who's not able to use their intersubjectivity and their mental states appropriately is likely to be overwhelmed by what cognition usually functions to balance. That is, emotion. So they present with a dysfunctional dysregulation of affect, which actually corresponds to a dysfunction of cognition. Peter Fonagy states that it's in this absence of appropriate cognition that makes affect overly influential for people on the borderline spectrum. So it's because cognition is dysfunctional, for clinicians to intervene at the level of cognition is puerile, because the capacity is missing. So in other words, so clinicians, according to this particular stance, first of all need to bring down the emotional arousal in order to help the client restore their cognition and thus restore the balance. The view is that there's no use trying to change the way a person construes their view of the world if they don't have a capacity to process it in the first place. So it's a first port, in a sense, of entry. It's this beginning of, before we start anything, let's have a look at the capacity the person might have to actually hold some awareness of how they're feeling and experiencing things, and another as well. And before one can find this sort of balance in the emotional state, it's very difficult to progress. And I think often that's one of the problems we experience clinically. We just plough on, we keep going, and the person's just, as said earlier, just goes along with it. A very important part of MBT is getting the patient, the client's perspective from the beginning. So everything's aimed at trying to help them begin to think about having the diagnosis, what it's meant for them, what it's meant for other people. That's sort of where you start. So, okay, so I'll just give a very quick clinical example here of just an experience I had. So this particular client arrived 30 minutes early for an MBT group that I was running. It was about four mums who had borderline personality disorder who were very unwell, and their little children, so babies to about 2. So when I went into the room, I noticed that this client had actually set the room up already, which was part of our arrangement, but I noticed she was very agitated, and her 2-year-old son sat away from her. He looked really sullen and scared. The 3 of us, that's my client and her son and I, sat on the floor together, and I said that I noticed that she seemed upset, and that her son did too, and I asked her if that was so. So this is the first port in a way, is trying to get an idea of the affect. She told me that she'd yelled at her son and that she felt really angry, and that when she was collecting the toys from the toy room for the group, she felt paranoid when other women at the centre looked at her. I said I was surprised to hear she'd use that word, and I was sorry that she felt that way, and I wondered what had made her feel it. So in a sense, this is I try to really connect with the empathy of the state, of something that for this person has become huge. She's extremely upset. So you pay attention to that. I asked her what made her feel paranoid, and she said it was the look they gave her, which is clinicians, you often hear that, it's the look. With an MBT approach, you'll say something like, the look? What was the look? What were you seeing? And she said, well, you know, like the look. Again, you're not put up, you stay just with something very simple like that. And I said, well, actually, I didn't know. I said, and I didn't know what it felt like for her. So I asked her if she could help me understand. This actually quietened her. Her arousal level went down, and that's the aim of this, is simply to bring the arousal down so that we can actually begin to sort of think together. And with that, she did begin to talk about some of the options, and so I said, well, what do you think that woman with the green top was, why was she looking at you? What went through your mind about that? So it's an attempt to get a person to become more flexible, to think about things instead of the black and white, the rigid thinking. So that was going okay, but all of a sudden, she got really angry, and she just told me, stop, So I had obviously, gone off track a bit and sort of got a bit careless, and I wasn't monitoring. And her arousal had gone up again. So she was clearly very angry with me, and I said, well, I thought, I've said something. What just happened then? Can you perhaps let me know? What did I do? You take ownership for it as the clinician, that there's something that actually you've done, that's triggered it. And I actually apologised. And I said, I wonder if we could just think about what happened. So this again just sort of calms the aim, and it does work. It is very calming. She actually answered me. She said, how can you ask me to think about someone else? I'm sick of thinking about others. Things have never been about my own needs. No one's ever thought about me. So simply by asking her about how did someone else think, with the repeated sort of focus on that, had again increased her arousal, but at least by paying attention to it, we could address it. Oh goodness, I've just run out. 1 minute, I don't believe it. I did want to just show you very briefly, I will actually skip to the very brief viewing of Anthony Bateman. Perhaps you can come and help me, because I think... I'll just say, actually, I might just leave it at this. If I only got 1 minute, I probably need to just say this. Okay.
So do you want to go to this?
Yeah, I'll do this. I think the main thing that I wanted to make the point about here was that the aim is to increase the robust nature of a person's capacity with borderline personality, to sort of make their capacity to think, to hold a reflective position
Okay, Lucy.
more robust.
How have you been over the last week then?
This is Anthony. This is a role play.
Been good?
Been good?
Yeah.
What sort of good is that? Is that good or ordinary good or?
No, I think I've been pretty... Had a lot on, but yeah, it's been good.
Okay. Can I check out what good this is? How have you been? I still need to know what's the good. Is it a good shut up Bateman now, or good I'm not going to talk about anything? What sort of good is that?
No,
Is that good or
I've had some difficult...
ordinary good or?
Difficult things the last few days, but I think I've been dealing with a lot on, but yeah, it's been good.
Tell me what you've been dealing with. Can I check out what good this is?
Well, Monday was the court. I went to court.
You went to court?
Yeah.
That's a surprise to me. I mean, was that a surprise?
I didn't know it was going to happen until... Well, they told me on Friday that it was
Right.
penciled in.
Okay.
But,
On Friday for Monday, they told
Yeah.
you. God, how did you manage that?
weekend I was pretty nervous. And then Monday morning I was called in. It was supposed to start at 11, so I got there. I got there early.
Well, I'm not surprised you were nervous for a kick-off.
Yeah.
I mean, that's pretty sudden, isn't it?
Yeah, and it's been hanging over my head for ages. So
Yeah.
I just wanted to be in the best, state of mind for it.
Absolutely.
Yeah.
So, were you able to keep in a reasonable state of mind over the weekend, and then you got there early? Is that...
Yeah. Well, no, I would have been fine. I got there at 10 because we were supposed to be going in at 11.
Yeah.
So I'd already been waiting till 11, and then...
So you're all ready?
Yeah, exactly, outside.
Sorted, yeah.
And then got there, and I didn't see anyone. I was in my own little room outside. And then at 11 o'clock it came, and no one came to get...
Okay, look, you'll find that there's a lot of material on the web. I've run out of time. What I'd rather say is that what you might notice there is that when, at the very beginning, what we often get is how, if you are a clinician that does in fact ask how the person is, you might get good. What Anthony does there is, what kind of good is good? You see, so he's initially beginning with trying to establish the affect, not to just let that statement go. Is it a good, you want to get rid of Bateman Day, or, it actually is a very active clinical stance. So he's, the other part of that is really he was actively engaged in being on her side. So that, again, I think is often something that we as clinicians can let slip. We definitely take responsibility for things that are going on, you just, because in a sense the theory is that you're presenting another mind to a person so that they can experience something different. Do you notice he said, well, I was surprised. So he puts his experience, or the clinician puts their experience in as their experience. They don't say something like, you must have felt very surprised. So you see the subtle differences in this. It is a very technique-laden approach. It takes quite a lot of supervision, but it is I'm finding it very useful in working particularly with, with people with borderline personality disorder. Thank you. I'm sorry I ran out of time.
Thank you, Clara. Now, as probably most of you know with YouTube, if any of you have written down the YouTube address, it will take you to other examples of exactly the same sort of processes. So hopefully you've written that down. Okay. All right.